and interim executive head of strategic investments, innovation, and impact at Kenya. We'll start with Dr.
No, I can take
Please give a round of applause for
Thanks, Chair.
Kwezi, i-password kusende WhatsApp. Yeah. Okay, so please for
The name of the
network, man.
Mkombesi.
I'm not going to the data, therefore, I'll just speak from what we had. The chair will guide me to the time. I don't know how much time I have, but South Africa and I want to was tested and brought into start the COVID-19 pandemic remains an inflection point that behoves our continent at large. South Africa to reimagine effective, efficient, and other measures which can predict and hence proactively prevent future pandemics if they do okay. But if they don't, we must be prepared to respond to any pandemic in the future. The World Health Organization cautions that the COVID-19 pandemic, in as much as we know that it was not the first, it is certainly also not the last. As speaker after speaker this morning spoke, there is another pertinent pandemic in the form of mpox, which has been declared as by the Africa CDC as a public health emergency, which require mobilization of resources across the continent. It requires all hands on deck or on board. Lessons we learned from the COVID-19 pandemic and the success in combating it is that there is a need for a collaboration and partnerships among one, international and national governments, number two, academia, including universities, science councils, and public health entities. And the third part of the collaboration is the private sector, including multinational pharmaceutical companies, and the last leg is communities and civil society in general. Continuing inadequacies in our ability to predict and prevent pandemic spreads highlight the critical role of preventing upstream infectious disease transmissions. Vaccine hesitancy emphasizes the importance of engagement with all sectors of our society. Our country's unfortunate familiarity with long-standing HIV/AIDS and TB dual epidemics provided valuable scientific expertise and infrastructure to assist Africa's response to the COVID-19 pandemic and our contribution to the global response back then. However, perennial and persistent shortages in funding of these areas and the complex and wide-reaching health socio-economic effects of the COVID-19 pandemic laid bare necessities to establish a multi-sectorial entity that can urgently engage in interconnected research, development, and innovation initiatives to strengthen our current disease control strategies and also enable us to respond rapidly to and even prevent future pandemics. And accordingly, precisely on the 8th of March 2022, I know the precise date because I am in charge of leading the NRF in establishing what we call a national, or what we then call the National Institute for Prevention and Preparedness of the Pandemic. So that day on 18th of March the NRF in partnership with the DSI opened a call for concept proposal for establishment of the Institute for the Prevention and Preparedness of Pandemic. In short, we call it IPQ. For all South African public universities and relevant research institutions. After the rigorous peer reviewing process and shortlisting, which was subsequently followed by a proposal from shortlisted institutions in July 2021, the shortlisted institutions, instead of submitting competing a proposal, they form a consortium. It is a consortium of multidisciplinary and multi-institutions. It was initially comprised of 8 universities, but has since expanded to 10 universities. The consortium submitted a proposal which was deemed as compelling, as duly adjudicated by an independent panel of international experts. The IPQ is an inclusive, multi-sectorial, and interdisciplinary research and innovation outreach that will take a holistic approach to anticipating, responding to, and recovering from any future pandemic or pandemic threat. The approach is characterized by rapid and robust action, agility in response to real-time data, interdisciplinary translation, accessibility, and report management. It is on 5 goals. The first is to strengthen detection and monitoring of emerging threats. Secondly, to reduce the emergence and spread of pandemics. Third, to improve efficacy and accessibility and treatments. And the fifth is to mitigate social and economic fallout of pandemic prevention. And the fifth is to apply learnings to improve future responses to pandemics, whether during or between pandemics. It consists of 6 thematic centers, which I will not elaborate on, because I'm afraid I will not take this time. It aligns with international and national imperatives at the international level. The IPQ specifically aligns with at least 3 UN SDGs, Sustainable Development Goals. The first one is goal number 3 on health and well-being. Goal number 4, quality education. Goal number 9, on industry, innovation, and infrastructure. And goal number 17, on partnerships. At the continental level, it aligns with the EU Vision 2063. The Africa we aspire for, specifically to Pillar 1 of a high standard of living, quality of life, and well-being of all citizens. Pillar 2 on well-educated citizens and skills evolution obtained by science, technology, and innovation. And Pillar 3 on healthy and well-managed citizens. It also aligns with the STIAS, Science, Technology, and Innovation Strategy for Africa 2024. At the national level, the IPQ aligns with the National Development Agenda Vision 2030. A goal for equitable and inclusive health, as well as health and human rights by promoting physical and mental health and well-being, and to extend life expectancy. It aligns and also gives expression to the implementation of the STI digital plan, thanks to what Bonisa spoke about, in particular, the health innovation STI domain. And at the organizational level, the NRF, it is promoted
Which means
it aligns with the ties, transformation, impact, excellence, and sustainability. And I can see that but then,
but why
I think I should conclude when the minister ended to bring emphasis to what I spoke about of health as a universal right. He mentioned that our founding father of democracy, Nelson Mandela, was very passionate and vocal about health as a human right. However, that view has been widely held for more than 160 years. In 1860, the American philosopher Ralph Waldo Emerson wrote that the first wealth is health. This quote is a reminder that good health is the foundation for building a life, community, and economy. It also connotes that health is a fundamental human right and a key indicator of sustainable development. Thanks.
Thank you, Dr. Lopez. Our next speaker is Dr. Shekhnat Govind. She's a seasoned microbiologist with distinguished career spanning over 2 decades. She used to be the chair of the Interministerial Committee on Medical School. She has specialized in microbiology since 2001. I tried not to read this, it was very small. She's currently the notable tenure at the Lancet Labs in KwaZulu-Natal since 2008. She will be presenting on the strategies to address antimicrobial resistance. Dr. Shekhnat.
Thanks for organizing the invitation to speak here today. Just going to wait for a minute for the slides to come up. We can tackle a little bit from the earlier speaker, looking at ways to counter antimicrobial.
The first one.
The previous meeting was just have very few slides, speak for a few minutes, really it's just to initiate discussion, conversation, and questions. So nevertheless, a strategy to address antimicrobial resistance. I think the first point really is to say that if we are looking at strategies to address the problem, do we know what the extent of the problem is? So do we know how big a problem antimicrobial resistance is in South Africa? And the answer to that is a resounding yes. And I'll just put a screenshot of some of the data that is available. So for the past 15 years now, antimicrobial surveillance data has been very effectively collected and collated from both public and private sectors. NIC, the National Institute of Communicable Diseases, is the gatekeeper of this data. And this is available, I'd like to say real time, it really is updated every quarterly, and it shows you both public and private sector data per organism, per antibiotic, for pretty much just about any information you would like. So yes, the simple answer is yes, we do have a pretty good idea of what the extent of the problem is in South Africa in terms of AMR. And we've then put all of this data once it's free available on the website. Under the umbrella of the National Department of Health, we put together a report on the surveillance of antimicrobial resistance and consumption. And the last one is just waiting ministerial approval before we publish it. So there are many gaps here. I speak from the perspective of human health, and I know we're sitting here in a One Health setting. So yes, whilst I may have inaccurate data on antimicrobial resistance in humans, we are very much lacking in our status. So yes, we need, and I'm sorry to expand on that a little later, but we do need data on animal sector, on antimicrobial usage, antimicrobial resistance, and certainly something is available from agriculture as well. This is how it began in 2017. Antimicrobial resistance national strategy framework was developed and slowly expanded on, or it started being a very much human health directed initiative, and it was expanded thereafter to include animal health, and then went into environmental health as well. And within the strategy framework, a MAP AMR was convened. And this MAP AMR rests essentially on 4 pillars, and these are 4 pillars that we basically used to say, although we don't look at them in silos, but say these are the areas that we look at expanding on growing in order to mitigate AMR. And the four pillars, and sorry, there's a lot of writing on this slide, but I'll talk to it in my next slide, which is the last one. So it's really just to say that the four pillars are diagnostic stewardship, surveillance, infection prevention and control, and vaccines, as well as antimicrobial stewardship. And as for the brief, what were the strategies to address? I think there are a number of issues. So the slide is by no means comprehensive. I think there are a number of issues in each of those various pillars that I've mentioned that we've got to look at. And I think the very first and foremost is our governance strategy. And I think that's imperative to recognize and to address. In fact, I've been introduced as the past chair of the macro AMR, and this is because the macro AMR is actually being technically disbanded. Because it's been quite a challenge, quite an uphill struggle to incorporate One Health strategies and One Health concept and the program that sits under the So yes, we've got to look at governance changes. We are proposing that there is a One Health office, One Health, which incorporates buy-in from the Department of Health, human health, animal health, DAPs, DALRES, all of those, because we would require all of that buy-in at the ministerial level in order to make strategies work for One Health concept. Then surveillance I've touched on very briefly already. Whilst we have once again excellent data on AMR surveillance in humans, we are lacking in that in the animal sector, and there are lots of pockets of work that are available from the environmental sector as well, all of which has to be brought into or under one umbrella of surveillance. And then being a microbiologist, diagnostics obviously is something very close to my heart, and I can certainly attest to the fact that in the past few years there's been an absolute explosion of diagnostic modalities available, especially for molecular testing. And whilst we've got to use these appropriately and make sure that they are quality checked, I think one of the challenges that we have, and obviously we have the public and private sector in South African setting, is that whilst these may be freely available in the private sector, unfortunately it's very challenging and they price prohibitive to make this freely available in the public sector. And this is a huge support to effective stewardship measures. Infection prevention and control, this to me forms the very foundation or underpins all our stewardship efforts. And unfortunately, I think that would be a talk on its own to outline all the challenges that we currently have around providing adequate infection prevention and control at the various levels. Antibiotic stewardship is a fairly broad term. So essentially, you've got to think of stewarding the antibiotic at the prescribed level. What do we have in place to do that? And yes, the public sector, there are many factors at play here. So, for example, you have a formulary, you've got restriction of formulary, you've got organization for the use of certain antibiotics. But unfortunately, not so. The private sector is really for all. And if one moves away from human health, you've got to examine what the legislation or policy is around the use of antimicrobial agents both in animal health, and this is not necessarily health per se, but growth promotion as well as the agricultural sector. So we really got to look at legislative and policy reform there. Vaccines, I guess I really don't need to expand on this. We've had an entire morning of listening to vaccines and the importance and the relevance of this. And obviously, when I place it in this context, I speak to it as a strategy, a very important strategy to address AMR. And if I can just make one point around it, is speak a lot about the EPIs, and we talk a lot about childhood vaccines, but there's a hugely important role that vaccines play in the elderly as well. And this is something that we need to consider going forward. Education, yes, we've looked at introducing stewardship in the curriculum. I must say, well, it may give away my age when I was a medical student, because never the concept of antimicrobial stewardship, let alone it being part of the curriculum. So it definitely is there for undergraduate studies, but once again, we're expanding it outside of human health. The last one really is just to look at communication and awareness, and this is primarily directed towards consumers, the users of these antimicrobial products and medications. So information and advocacy there, I think, is very critical. And we've got to do all of this keeping the One Health concept in mind. So I think that is my final slide. And thank you for your attention.
Thank you, Dr. China. I think we can make it on time. Very well on time. Our next speaker is Ms. Tolu Disu, an independent consultant with Global Health Life Science. Her presentation is going to be building robust and sustainable R&D program to support a strong health system. Ms. Disu.
Thank you, Chair, and it's a pleasure to be here to share the stage with my fellow co-panelists, as well as to hear and listen to the audience. So I'll just wait for my presentation to be concluded. $1.5 to $3 billion. Anyone wants to hazard a guess as to what this number might represent? I'll tell you for the sake of time. It is the estimated funding gap in Africa as it relates to health R&D. It's a huge number. So to discuss how we can build a resilient and robust R&D system in the face of pandemics, I'll start by setting the scene as to what the health R&D landscape looks like in Africa, so we have a baseline knowledge. And then I will go ahead to link the R&D efforts that we have on the continent with pandemic preparedness and response, touching on what the impact was in the face of COVID-19 and the 2022 mpox outbreak, as well as what the paradigm shift would look like if we were to use the model framework called the 100 Days Mission. Subsequently, I'll tie all of these learnings we have from previous pandemic response to the global efforts to better prepare ourselves for pandemic threats into the essential building components as it relates to strengthening the R&D program for Africa. And I apologize, we have some reformatting issues, so the slides are somewhat out of focus. To start with, if we look at the space of R&D on the continent, we know that Africa is disproportionately low in R&D. We contribute just about 1.3% to the world, and this is despite the fact that we are about 17% of the world's population, and we carry 23% of the global disease burden, of which infectious disease, of course, is most prevalent. It's also important to understand the challenges, and the challenges are centered. There are myriad of challenges, but we can hone these down into three, which have to do with funding that we just talked about, the partnerships and collaboration as the second challenge, and the infrastructure and capacity building element. And I'll touch on these in the presentation. It's important to say that these challenges are not just specific to R&D, but we see them across the spectrum all the way to delivery, as well as uptake within the healthcare system. Notwithstanding the challenges, we still have a lot of opportunities in the R&D space as it relates to pandemic preparedness. The first thing to understand is that we have a rich biodiversity on the continent, which means that it's a perfect breeding ground for infectious disease. And in addition, we have an innate capability of African DNA being the oldest and the most diversified DNA in the world. And so what this means is that we have opportunity to develop solutions, medical countermeasures that are actually tailored and more applicable to Africa, not just Africa, but the extension of the globe at large. And so the whole world can benefit if we can actually exploit these opportunities. Last thing too that I'll mention is that we also have the human capacity being the largest youthful population, as well as the fact that we have model institutions on the continent. So we all know that in the wake of the pandemic, Africa was really vulnerable in that we were faced with supply chain disruptions and we had access and equity issues. So this really reawakened the need for self-reliance on the continent, and we saw that leadership at national and at Pan-African levels. What this meant and translated is that we had catalytic projects, not just in the manufacturing space, but we did have selectivity in the R&D parts of the value chain as well. So we really started to see a more cohesive response all the way from monitoring and disease surveillance to uptake and delivery of medical countermeasures. The catch though is that most of the efforts, most of the gains that we saw in the wake of the pandemic were really focused more on the manufacturing side and more on fill and finish capacity. And so while there's need to continue to build on our vaccines capacity, we also need to look at other pandemic health products, diagnostics and therapeutics, and we also need to scale and make it more sustainable. And so therein lies the challenge that we have upon us. Now, to understand a way we can better address, we can look at the 100 days vision, which is a paradigm shift for outbreak response. The 100 days mission is really an initiative that looks to ensure that we have medical countermeasures that can be developed and approved at a 100-day mark post a declaration of public health emergency of international concern. The essence of the 100 days mission is really to make sure that we can produce these medical countermeasures in record time, under the 100 days, and that we can actually save lives and have a very healthy impact in the process. And I do have to say that even though this is a globally coordinated effort, it's very much applicable to the Africa space because it was developed with Africa input, as well as it centers equity and access at the heart of it. So it's really tailored towards a rural south outbreak response. So to achieve this 100-day mission, the important thing that we have to realize is that the work starts before the day zero, which is the public health emergency of international concern declaration. And it starts with us running this marathon of doing a number of things. The first is that we need to make sure that we have effective disease surveillance using a One Health approach. We've talked a lot about One Health in the last my last two speakers. And so that's the important thing is that needs to be ongoing. And the second piece is that we don't know what will be the next pandemic threat, right? We don't know which pathogen will attack us. And so we need to be strategic in looking at platform technologies that are pathogen agnostic. And we need to consolidate and share the knowledge that we have by building a repository of medical countermeasure libraries. And so a third component is that we need to keep the base ward as it relates to our clinical and manufacturing sites, and we need to strengthen our regulatory processes. And the fourth component of the enabler for this 100 days mission is really to make sure that we have pre-agreed pandemic instruments in place. So whether that has to do with the financing agreement or the agreements we have around product development and distribution, all of these need to be in place way before we actually declare these health emergencies. And the impact post day 100 is that at the day 100 mark, we need to be ready to scale up for production, and we need to do this in an equitable and accessible manner. So I will end the presentation just by saying that if we look at and draw the lessons from COVID-19 as well as the model that we have of the 100 days mission, there are a couple of building blocks that are essential to make sure that we can actually build a resilient and robust system in the face of health emergencies. And the first is that we need strategic plan and prioritization, and we have the strategic planning and prioritization at Africa level from the Africa CDC as well as from the WHO, the blueprints we have for R&D preparedness. It's important that we tie these R&D efforts into an outbreak response, and so strategic planning will be very important for that. It's also important that again that we're not working in a disjointed manner, we're working in a coordinated manner where we can identify these priority pathogen families and actually target them. The second piece has to do with funding. We've talked a lot about the huge gap and deficit that we have with funding. And to close it, we really need to be looking at diversifying our funding sources. We need to look at better finance instruments, and we need to look at sustainable financing models so that we can actually get that 1.5 to 3.3 billion US dollars, make that more tangible, more of a reality. The third piece has to do with capacity building and infrastructure development. We need to not only strengthen our research institutions, but we also need to train and retain our talent. And we need to be looking at building capacity for our labs and for our tech hubs, particularly in the fact that we need to look at a surveillance, a testing and a treating paradigm. The fourth component is collaboration and partnerships, which sounds like a buzzword because it's used so much, but the truth is that it really underpins what we're trying to do, and it's a critical component in pandemic preparedness, prevention, and response. And we're talking not just about public-private partnerships and multi-geography partnerships between global north and global south. We need to look at the researcher level. How do we bring some of these female researchers, and how do we make sure that it's a win-win situation for all parties involved? And then the fifth piece has to do with innovation and technology integration. To build a resilient health system, you have to innovate and you have to be able to adapt. And so leveraging technology such as platforms and libraries that I talked about, digital health and AI will really allow us to make this happen. So those are the 5 components, and cross-cutting these 5 components is the fact that we need to be doing this in an ongoing manner. So pandemic preparedness is now, it's today, and it's forever. It's not when we have these declarations. We need to do that, and we need to be guided by the access and equity. We need to build access and equity from the very start and very early in the R&D process. And that is how we will build a sustainable, secure, and robust health system in the face of pandemics. Thank you.
Dr. Baptiste Dungu. He's going to present on new frontiers in One Health. Dr. Baptiste Dungu is a veterinarian with a PhD in vaccinology and more than 25 years experience in vaccine research, development, manufacturing, regulatory quality, and commercialization. He has been worked in several institutions. Should I move? No. Well, I'll name a few of them. OVFN Laboratory, Unese Food Biological Products, Afrivet Design Biologics, MCI Santé Animal in Maroc, Dolvet Tokai, Government, etc., etc. Dr.
Thank you very much, Chair, and thanks for the opportunity to be here. I'm told that I will be back by in my presentation. I'll be talking about the new frontiers of One Health. We've been hearing about One Health in the past, with the previous presenters. So I'll give a little bit of a historical perspective to One Health and then move into what is led to the new concepts that are being talked about. And what are the new frontiers? Now, those of us who are over 30 years will remember that over the past 30 years there's been a number of global health issues that have occurred, starting from red cow disease until now. And then you see that all these diseases that you see listed there, all the diseases that are being listed, almost all of them are zoonotic. They have an animal origin, and that has been really the main problem that is occurring. Most of the pandemic or epidemics with pandemic duration have been zoonotic. Up to the most recent one that we're facing now, which is mpox, quite spread in Africa now, with the 2K that occurred. They all have a zoonotic aspect to it. Now, if we look at the past 20 or so years, there's been an acceleration in the number of zoonotic disease that have reached the pandemic level. And this has brought the main organization at global level to start seriously looking into the concept of One Health built around the zoonosis that have been occurring. So the four main organizations that I'm talking about is the FAO, the UN, the World Health Organization, the Animal Health Organization, the environmental, the United Nations Environmental Agency, but the most important event, as you can imagine, was the concept of One Health has evolved, especially for some of us as veterinarians. We've always had one case of zoonosis. Most of the time, when we interact with animals, we get exposed to disease that can be transmitted to humans. So for more than 100 years, what was called before one medicine, it was essentially medical doctors and veterinarians. But then as things evolved, the concept went into what one can call a narrow One Health, which was still zoonotic diseases, and then the issues of antimicrobial resistance started popping up. Until in 2006, 2004, that's when the concept of One Health, One World started really becoming important, especially after some of these big disease situation that occurred. And then after 2007, we moved into what is now seen as you can see, the evolution has been from human and animal health, then it became an environmental health to come on now, as you see, the new frontiers is much broader than that. We're looking beyond just environment. We're talking plants, we're talking microbiomes, and many other aspects that have become part of the concept of One Health. As I said earlier, we created the COVID situation after the big COVID situation, pandemic. The main organization that we were part of was World Contact, and essentially initially it was the World Health Organization, the non-health organization, joined by the United Nations Environmental Agency. They came up with what is called the Contact Alliance the Contact came up with a plan to see how to prevent this pandemic, but also to occur. So they came up with what is called now a joint plan of action, which has 7 action plans, as you can see on the slide. I won't go into detail. This is what is driving now the whole One Health process globally. Each country is working on a national action plan built around the action plan that has been established by the Contact. But one of the outcomes of this process was the establishment of the structure that is called One Health high-level panel of experts. I was privileged to be one of the 22 members of this panel. And this panel was put in place to look into coming up with guidance that would assist technically the health institutions in trying to come up with unified views of numbers for points. So that was established in 2021. And we had a clear mission to look into policy relevance, to scientific assessment, and to come up with guidance in terms of long-term strategy. But one of the main outputs of this panel of experts was to come up with a unified definition of One Health. We heard, I think, the chair, when we started the session, was really invested in the new definition of One Health, which is a unified definition which looks into One Health as a broad aspects, not only looking to health, human and animal health, but broadly looking into all the aspects of One Health. And this has become now the definition that is used. We looked also into what are the key drivers of pandemics that are occurring. We have the issues of civilization, migrations, urbanization. So these 6 aspects become really what is considered as the main drivers of all the epidemics and pandemics that are appearing, and also problems like antimicrobial resistance, as we heard earlier. And we came up also with a theory of change, which is driving basically the process of One Health. I won't go into detail with it. But what is more important is putting in place a surveillance strategy system. And these are what is driving the action plans that are being implemented at country level, but also at community levels. And another key activity was to look into putting together all the tools, to do an effective tools for One Health. And this is a manual task because almost on a daily basis we see more and more different fields identifying themselves as involved in One Health and then coming up with a wide range of populations. Sorry, I think that there's been a problem with the transition to this presentation. The slides are completely messed up. One event that is critical is One Health is the spillover, because that's what we're seeing from what is happening from wildlife or from animal custody to human. And spillovers are favored by those 6-pointed soil drivers. They are what I would leading to what we see now. For example, when folks know that it's coming from deforestation and the forest might be erosion of the animal, of the disease ending up into urban areas. So now looking into this, as I mentioned earlier, there's been an evolution from a very restrictive way of looking into One Health from human to animals, and then it moved into bringing the environment, and then now more and more it's getting broader. The concept of One Health is now identifying new frontiers, new areas where One Health is part of the overall One Health issue. Plant health is becoming a key element of One Health, but also the concept of microbiome. So I'll just go through slides and talk about plant health and microbiome in the context of One Health. I was thinking about it. In terms of plant health, it was quite obvious that certain stage plant health would become a component of One Health because of the fact that in the environment component, what plants are standalone. It says that the crops that we consume are also part of the One Health. So, an element of their own that contribute to the emergence of disease and so on. So, the field of plant health is becoming more and more very much part of the concept of One Health in different ways, looking into pesticides and looking into how the deforestation is contributing to the emergence of disease and so on. And then the other concept is the one microbiome being defined as trillions of microorganisms, that all the proteins that are all the molecules that are emanating from this relation of microbes, mainly bacteria. And we know that microbiome can find them in soil, in humans, in animals, but also in plants. And any disruption of the microbiome in the plant or in human or in the soil are having an impact on the health of the different components. Pesticides is an example that is being used a lot. As you start using pesticides, you destroy microbiome both in the soil but also sometimes in plants. And then they will have an effect on microbiome in humans or in animals. So it's becoming a big field of research because it's across all the different components, including the environment, but also the industry that is developing around it. Things like probiotics and so on are being developed as part of the looking into microbiomes as part of One Health. So that's really very quickly what One Health is the concept has become. Now the implementation is happening already, like I said, to put in place systems at the country level. I won't go into details. But the quadripartite has come up with guidelines that are being implemented at the national level. I would assume that there is already an application in the context of South Africa. And many other countries in the world are putting in place measures to first identify, do a meta-analysis of what health issues are in the country, and then how to translate it into applications. But also more specifically, clear plans are being put in place by certain countries to even identify area of research or area of technological application into coming up with solutions that address One Health issue. So that's really was a very, very superficial overview of the concept of One Health that we can discuss it, I guess. Thank you very much.
I'll just go straight to Dr. Susan Senze. She has close to 15 years experience in the field of public health and has worked on several surveillance studies, including post-vaccine introduction studies for pneumococcal conjugate and rotavirus vaccines, TB, HIV studies, and child health and mortality prevention surveillance pilot. She qualified as a medical doctor at the University of Zimbabwe and has a master's in public health and PhD in public health from the University of Witwatersrand. She holds a tenure as an associate professor at the University of Zimbabwe. She has recently completed the International Program in Public Health Leadership and is involved in Data to Policy Initiative as a trainer. Dr. Swenson has several publications, 35 publications, and also in published in international and local journals. Dr. Swenson.
Good afternoon, everyone. So we're asked to speak on pandemic preparedness and emerging threats, and I'll also touch on zoonosis. So in the last 2 weeks, Director Generals of both the WHO and the Africa CDC have declared mpox a public health emergency of international concern. We have learned in this meeting already that during COVID-19, we knew that it was not the only pandemic we were going to face. And now we have mpox, which is not just another health challenge, but a crisis that demands our collective action. So our world is changing as never before. The last speaker has really talked on zoonosis and how diseases of animal origin have been transmitted to humans, including avian influenza, rabies, Rift-Valley brucellosis. And these risks are increasing with globalization, climate change, and changes in human behavior, giving these pathogens opportunities to colonize new territories and evolve into new forms, as well as the growing problem of antimicrobial resistance. But what did we learn from COVID that we can apply to pandemic preparedness for future events? We learned that preparedness works. Health of everyone is everyone's business. The analogy today of people in the swimming pool and not just peeing on one end of the pool, that affects everyone else. No one is safe until everyone is safe, and our response must be agile and adaptive. Our response is guided first by international health regulations, which is really a set of legally binding instruments that have been agreed to by the state parties for prevention, detecting, and responding rapidly to threats. This takes an all-hazard approach, not just communicable disease, but any hazard. The core capacities of the IHR fall into four technical groups, which are to prevent, detect, respond, as well as IHR-related hazards and the point of entry and border health. And through these frameworks, we are able to monitor and evaluate how well we can respond to pandemics, starting with the ISPA, which state parties evaluate their own risk, be it communicable, be it climate change, drought, and take also after action reviews how well we respond to pathogens, how well we respond to previous outbreaks so that we can prepare better. Simulation exercises, if we were to have a pandemic, how are we going to respond, as well as voluntary external evaluation by other parties. So all these guiding documents then culminate in how well we respond. And this is just a picture taken last month, in which we are currently doing the joint external evaluation for South Africa. In all this, all we are trying to do is assess our capacity develop it, and then we can implement it so that we can respond better to pandemics. I'll rush through and talk about our approach now to pandemic response and emerging threats, and it's really focusing on improving pandemic preparedness for groups of pathogens based on their mode of transmission. So it recognizes that we have cross-cutting epidemics that are multi-hazard, and those groups that are relevant, for example, respiratory diseases, the arboviruses, we put those together, and then we also do preparedness for specific groups of pathogens, really with the aim to strengthen our existing system capacities, to fill gaps, and through this approach we avoid the silos, promote coherence and efficiency, and streamline actions at the time of the pandemic. So we have heard through these presentations more and more about the One Health approach, and that's avoiding the silos between human health, animal health, and environmental health, so that we can have coherence and efficiency in our response. We leverage on national health strategies, strategic tools for assessing risk, national pandemic response plans, to include the PRET approach, and then this then supports countries to build on what they already have, so that they can respond better to the next threat or the next pandemic. We commonly now talk about the 5 C's, and this is what will be a takeaway from this presentation, that we are doing collaborative surveillance. We want to look at community protection, emergency coordination, access to countermeasures, which is a lot of what is going on in this conference. We are talking about access to new vaccines, access to new medicines, as well as clinical care, or continuity of that care during epidemics. So at each stage of the pandemic, again, we are speaking to the 5 C's, whether we are still thinking about it pre-pandemic, or we have had the first case, we are in the middle of the pandemic, intra-pandemic, or post-pandemic. We are aligning our thoughts according to those 5 C's and core capacities, so that we can prepare better. And all this takes place within a healthy ecosystem, as well as all the sectors, the multi-sectoral approach. We learned about the impact that COVID had on education, for example, on economies. And so all that is part of the health system and our ecosystem in approaching and in preparing for pandemics. Our action, the 5 C's, and collaborative surveillance is our using the One Health approach. Again, we are strengthening and doing integrated disease surveillance, so that we can pick up threats quickly, but also that we have different sets of data that are feeding into our surveillance system. So, for example, now we have capacities in wastewater surveillance, in genomics, and all that is being augmented to what we already had. So our indicators have been based surveillance, to our laboratory surveillance, and other systems that we in place. Improving diagnostics and laboratory capacity. Part of the work now here is to also improve diagnostics that are made locally, but also that we can detect the risk, we can have early detection, we can respond, and we can summarize all the data into action, and that can be understood by everyone. Community protection, including risk communication. During COVID, we knew about the epidemic, within the epidemic, and this was an infodemic. And part of community protection and risk communication is making sure that communities are also at the center of the response, but that they also have enough information about the disease so that they can respond as well as keep themselves protected. We need safe and scalable care, emergency care systems that are ready to respond rapidly to ensure that communities have access to quality health care and that that care is also safe, as well as protecting our healthcare workers who are also at the core phase of patient care. Access to countermeasures, I won't talk much on this because this is the subject of this conference. To fast track R&D, have scalable manufacturing platforms, as well as a coordinated supply chain in emergency distribution, as well as the regulatory oversight. Lastly, the last C is emergency coordination, which speaks to our strengthened health emergency preparedness and response capacity and coordination. Really, the context of all this is that we have governance. A colleague here spoke about governance, the systems, as well as the financing. We had about a $3 billion gap. That's just for R&D. But we need to finance more. We need to finance the countermeasures. We need to finance our response in pandemic preparedness. Lastly, for us to be better prepared as nations, as countries, to the next pandemic, we need system level thinking. And that means that the politics, the economics, the medical, the social, the development, all have to come together and have to be part of our way of thinking as we prepare for epidemics. Thank you.
Our last speaker is Dr. Musa Mabasu. He's a biologist and a research director in public health at the Human Science Research Council. Dr. Mabasu scientific domain includes infectious disease, epidemiology, and biostatistics. His primary research field is public health, interested in disease surveillance and analysis of epidemic situations. Current research focuses on determinants of health status to inform and evaluate public health interventions. Dr. Mabasu.
Ladies and gentlemen, initially I was lost, but since I've listened to all the panel speakers, I believe I'm right. So I've been asked to give a talk about, the emerging and emerging threats and the global initiatives that are available for us to mitigate their impact. And by and large, these are mainly infectious diseases. And I'm glad that Professor Lungu was here, the last speaker was here, because I'm also following the same line of thought. So my presentation outline, I'll try to be faster. My approach is that we need to look at the nature of these threats. And it's quite clear that they're quite complex in the African context. Because of a number of influences that I'm going to touch on those. And then again, quite a number of these initiatives have been dealt with here. So I'm going to touch based on those. And I think that in terms of network and collaboration, we all agree what this can happen. So the emergence of these threats is a result of and what we is talking about here is, not even here, we're talking about the emergence of the new diseases. But we also have other problems in Africa, resistance of pathogens to antibiotics and antimicrobials. The emergence of once controlled diseases, some we thought that will be eliminated. But of course, and the subject of many sessions today is the emergence of the new diseases as we see them to date. And this is all happening because of human movement. And this has been subject of discussion in the panel today. So, and you know which ones are the main countries? The four. In fact, the first three in Africa. But I think it's better to look at them this way. I think Professor Nkuzi maybe touched on the fact that some of them are zoonotic, and in fact, a lot of the diseases that we have come from wild animals. And the tricky thing about this is that you have viruses, you have influenza, you have a combination of these. So there's zoonotic diseases. Combination of them, some of them are viruses, some of them are bacteria, some of them are parasites. I don't mention all of this, but it's quite a number. It's a list of them. And it tells us that there's a complex situation in Africa. So, what many people do not discuss and say much about is what you're facing with in terms of this for all of them. So, it's TB or it's bacteria, viruses, and parasites in Africa. It's a major problem. And then, obviously, and some of my colleagues have already touched on this, the environmental drivers. And climate change is here to stay. So we've got to start to think, what do we do? And what is of concern is the occurrence of these extreme climatic events and the frequency with which they occur. They change habitats, they create environments where new pathogens thrive when populations have not been exposed. They even change the geographical distribution of diseases. And I think one other thing that I wanted to highlight here is this element of drought. It causes extreme hunger, it leads to poverty, and related disease outbreak. This is Africa. And land use change in Africa is a big issue. We can talk about, personally talk about deforestation. That's one element. Deforestation is a big problem. But also in West Africa, where it's dry, there are irrigation systems for rice. It introduces mosquitoes that carry malaria. In some instances, to populations that have no herd immunity. And here I just mentioned air pollution problem, but I think you mentioned it's pollution in general. So what should we do? What are these initiatives? Everyone has been talking about them. I think the last week had not yet off. We need, and what has been happening, we need to continue do what we've been doing, but I'm emphasizing the fact that we need to build this inventory of these threats. And for a lot of organizations, I call them smart databases today, because in the past, if you travel in Southern Africa, you'll find spreadsheets. People will have thresholds, this threshold, something is happening. We've since progressed, we've since moved with technology. We are now looking at data-driven simulations. For example, with one good example would be COVID. We could actually project what the care was going to look like. So we need to build and strengthen this capacity. And most importantly, establish systems for rapid detection, diagnosis, and containment of these threats. And here we are talking about what everyone here has been talking about, early warning systems to improve our preparedness and response. So all of the things that I've mentioned, from my own perspective of disease surveillance and epidemic analysis, and I think we need to strengthen disease surveillance, applied research in terms of implementation science, and what. And I'm mentioning all the institutions, including KZN, because there's quite a lot that is being done by the universities in South Africa, but also by sister institutions, including HSRC. But if we're working in silos, there's a lot of potential for us to work together. These institutions and these universities are already working in collaboration with regional, sub-regional, and international agencies. And this was discussed in the plenary. So we've got to start to work together, and I'll show you what happened because of COVID. So our response is multi-sectoral, and it does rely on the complex network. And it does, it's also intergovernmental, it's not one department. It also includes NGOs, but also specialized agencies that I listed in my previous slide. And I'm not going to say about One Health because a lot of been done in this area and it's progressed. So, let me grasp my own remarks. I think there's one slide that I missed. But suffice to say, the duplication of activities, we realized this when we started working during the COVID epidemic. We actually work together and we keep it financial resources that we had, pull things together, and we started working together. So, and we can learn from the lessons that we learned recently and what is happening currently with the new health measures. And to see what are we doing in terms of policies, in terms of strategies, expertise that we have, and what we call tools or platforms. But I think for me, what I'm much more passionate about is this capacity building programs. Because that's what we need in Africa. For us to effectively address the growing and globalized threat of these infectious diseases. And with that said, I think that's my last slide. Thank you.
I'll take one or two questions. We're running out of time. Any questions on this side? That's okay. Any questions on this side? Okay. There's a wish from one of the presenters. I think we have bio. So I have to do it.
Long shots. There's no long shots.
Ms. Tolu Disu. She is a senior global health and life science professional with 16 years experience in biotech, healthcare, consulting, public health, medical tech sectors in strategic commercial program management and director capacities. With specialties in primary care, including vaccines, R&D, and precision medicine. Tuli's experience is highlighted by scientific research roles with GSK, Merck, advancement of first-of-a-kind projects and business development of GE Healthcare, GE Life Sciences. Do you want me to read all? She has a lot. Thank you very much. Colleagues, thank you very much for saying your question. We can go for a break. I think there's a break now, and then the last session will be from 4 o'clock to 5.
Hopefully, holding stand. Yeah. Yeah.
But there's another session for which I'm sure we will. That's what we can check.
Wait. Yeah, Mango. Let's start table 1 and 2. Labatatu 1.
Hey.
We took the time.
Hey. Man.
I'm going to put the deal on 12. Okay.